A very good afternoon to everyone. The topic of my presentation is clinical profile and visual outcomes in patient with traumatic optic neuropathy. Coming to introduction, TUN is potentially blinding complication of head trauma. Indirect damage to optic nerve is the most common form of TUN, occurring in about 1 to 5% of all cases of closed head trauma. Direct optic nerve injuries are rare, and there is no conclusive evidence for standardized treatment protocol for this blinding condition. The aim were to evaluate the clinical presentation and visual outcomes. It was hospital-based cross-sectional study. The sample size was 26 patients, and duration of study was for 6 months. Inclusion criteria were history of impact to head or orbit irrespective of age and gender, and post-trauma reduced visual acuity, and presence of RAPD defect, color vision defect, field defect, and fundus changes. The exclusion criteria were patients with pre-existing ocular abnormalities that might affect the visual function, and patients with other associated ocular injuries that may affect vision or its outcome, and the patient who did not consent for the study. Coming to material methods, visual acuity was recorded using Snellen chart at time of presentation. Intraocular pressure measurement was done wherever possible. Pupil assessment for RAPD was done. Fundus examination was done by indirect ophthalmoscopy, 90D slit lamp biomicroscopy, and OCT. All these tests were repeated after 1 week and 1 month. All these patients underwent CT scan. IV methylpred 1 gram was given, diluted in 100 ml normal saline over 45 minutes for 3 days, followed by oral prednisolone 1 milligram per kg in tapering doses were administered for a period of 2 weeks. Patients were examined every day during hospitalization and later at first week, second week, and after 1 month. 6 patients were managed conservatively due to contraindications for giving steroid like delayed presentation or uncontrolled diabetes. Coming to results and observation, the mean age of presentation was around 40 years. Male predominance, right eye was most commonly involved. RTA was the most common cause, around 83%, and baseline visual acuity around 70% or less than 6/60. Associated injuries which were considered most common, there was periorbital edema and ecchymosis associated, and also subconjunctival hemorrhage, lead lacerations, and some microhyphema. Coming to the orbital wall fractures, most common finding was of lateral wall, zygomatic, followed by medial wall, orbital floor, and orbital roof. In skull fracture, most common finding was of frontal bone, followed by basal skull, parietal bone, and occipital bone. No fracture was seen in 5 patients. With steroid, the baseline visual acuity, the p-value was less than 0.001, which was statistically significant, and without steroid, these were not significant. This is the box and whisker plot showing the treated and untreated group. In treated group, after follow-up, the logMAR value is close to 1, which is a statistically significant improvement. Of 26 patients, 5 patients had presenting vision more than 6/60 and 21 had less than 6/60. 20 out of 26 patients received intravenous and oral steroid. Of them, more than 2-line improvement was seen in 12 patients. 13% and final vision outcome of less than 6/60. Significant difference between baseline visual acuity and post-treatment visual acuity at 1 month review was noted in patients who received steroid. Of the 6 patients managed conservatively, no significant improvement was seen. Coming to discussion, TUN is an ophthalmic emergency. Treatment for this devastating cause of vision loss is not yet standardized. The most common cause of TUN was RTA, and young males were predominant victims. Associated skull orbital eye involvement vary depending on severity. Steroid treatment in TUN has been greatly influenced by National Acute Spinal Cord Injury Study that concluded that megadose steroid used within 8 hour injury showed better neurological outcomes. However, this was in contrast with the CRASH study. In our study, high-dose regimen similar to optic neuritis treatment trial ONTT was given. 26 patients in my study, 26 patients, 6 patients were untreated, and 20 received corticosteroid. The results of statistically significant visual improvement were 0% in treated group and about 56% treated group. Total number of patients in my study were 26. TUN in the middle age group was more common, which was consistent with study done by Rajnigant et al. And the study conducted by Chow et al. Predominant head trauma origins were attributed to RTA. Studies by Levin et al., Intras et al. Have demonstrated that treating TUN, whether with corticosteroid, extracranial decompression, or combination, yields better improvement in visual acuity compared to the conservative management alone. Coming to conclusion, regimen IV methylprednisolone as proposed by ONT is safe and effective in managing T1 patient presenting within 3 days of onset of defective vision. With steroid visual outcome was good as compared to patient managed conservatively. Those with baseline vision less than 6/60 and those managed conservatively did not show statistically significant improvement. Thank you.
Thank you. So just take care of the time as well. Was there a what was the mean duration between the injury to you giving the steroids in these patients, and were they able to actually do a proper assessment of the baseline visual acuity, because a lot of them may have
So mean duration the patient presented were at least for 1 week. If within 1 week they has presented and there was no contraindication, then I have given the steroid.
Because that makes a big difference to outcome, right? And normally
Yes,
we want to give it soon, right away.
Yes.
And also in terms of the the baseline parameters, you were able to assess them adequately with with low vision, below 6/60. It's very difficult to assess 2 meters or 3 meters or what difference happens.
Sir, yes, sir. I was successful to adjust, and I've included those person only. Those were in the criteria, and those were fit for assessment also, sir.
Okay, so that does rule out some of the severer.
Yes.
Okay.
Did you say IOP wherever possible in your presentation, or all cases?
No, sir. Whichever patient measure were RTA cases, so wherever it was possible, IOP was measured. Not all cases, sir.
Okay. Why was it not possible? Some method we can use, isn't it? There are so many methods of assessing. I just wanted to know
Yes,
that.
sir. Some patients are were
Okay.
not cooperative or having late severe lead edema, so there was not possible for IOP measure.
Thank you.